Fat grafting is a very versatile tool to always have in the armamentarium of a cosmetic and a reconstructive surgeon. It can be used not only for cosmetic features to enhance the lips, the cheeks, the temples, under the eyes, and lift the eyebrows, but can also be very versatile for reconstructing post-traumatic defects. It's been used for quite some time, and we're continuing to refine our techniques. The addition of platelet-rich plasma has proved to be very effective in the long-term stability of fat. Today I'm going to walk you through how I do fat transfer in my clinic, walk you through the markings and some of the procedure. So to start off, any fat transferring procedure, we want to make sure that we have good markings. Now, for this particular case, our patients graciously let us use her as an example, but she had a traumatic insult here where she lost a lot of volume. So initially, we used some hyaluronic acid filler to match the right and the left side, and we had a really nice result. And that lasted probably 12 months or so. We had a decent duration for it, but now it's time that we just do something more permanent. So we're gonna harvest fat today. My preferred harvest sites are the legs, and that's for a number of reasons. I would prefer the legs, one, because I like the quality of fat. I like the ease of access at that area. For the most part, I don't have to worry about things like I would in the abdomen, like hernias or diastasis or other things. So it's a very quick, easy way to harvest the fat. It's readily available, and for me, there's just less risk of complications. So we'll take the fat today, we'll separate it down, and then we're going to also take platelet-rich plasma. So we'll draw some blood from her arm, and then we'll mix that platelet-rich plasma with our fat in basically a 1 cc PRP to 9 cc of fat ratio. So you can see, here's our defect. This is the margin on which we're going to fill. So we're going to outline the margin, and also because of the location, I'll mark out the inferior border of the mandible as well as the malar prominence. And I'll do the same thing on the other side. And this will give me a nice representation, especially when I look at her from multiple angles, to make sure that I have the fill that I would like to have. The nice thing about this is, although she has lost volume here, it's relatively, tissue is relatively freely movable, so there's not a lot of scar tissue. Sometimes, especially when you're doing post-traumatic defects, the scar band can be a significant barrier and often takes multiple sessions. Now, I'll tell everyone who we're doing fat transfer on that this may take, a couple sessions to do. But what I've found that by adding platelet-rich plasma to the fat transfer, I'm getting a lot better acceptance rates or take rates than what I was getting prior to adding that on. So for most of the patients, this has been a one and done thing, but everybody understands that this may take multiple sessions to get to the desired result. But really, there's our defect, and we're just gonna fill in this. So I'm gonna anticipate that this is probably gonna take somewhere between 3 and 4 cc's, which means that I'm going to harvest roughly 4 to 5 times more. So for most of these patients, that's sort of my go-to. I'll take about 5 times more lipoaspirate than what I'm actually going to need, because I know that after I centrifuge it off, I'm going to remove the infranatant layer and the supernatant layer and keep the fat right in between. So I'll take a little bit more than needed. I also always tell my patients that I am not lipocontouring. I'm not giving you liposuction to your thighs for any purpose other than to harvest. So here she's had some harvesting sites for valve venous repair or arterial repair. So I'm going to avoid this area if possible, just because, again, I want this to be safe, and I can harvest enough fat from other regions that I don't want to compromise potentially anything that's happening here. So I have a nice amount of fat that's right down here. This is actually very nice fat for the knees. If you read some of the early articles, the preferred harvest site was the medial knee. So I'm going to focus here, I'm going to focus here. and focus here, and that should actually give us plenty. Again, I'm going to avoid this region here just because I don't see any reason to go through that scarred plane if I don't have to. Okay? So we pripped out the legs. I did a little bit of infiltration of 1% lidocaine with 1 to 100,000 epinephrine at the injection sites. I'm going to inject my tumescent today just manually with a 20 cc syringe on a 25 gauge spinal needle. So at my injection point, I'm just going subcutaneous in the same plane we're going to be at. And slowly withdraw. We're doing this with deep sedation, Versed, fentanyl. We'll give a little bit of ketamine, and then we'll do a propofol infusion. I'm doing this now just basically for time-saving purposes, so we have time for our tumescent to kick in. So again, the whole premise with tumescent is to vasoconstrict and have the least amount of a bloody field as possible. And so I'm just going subcutaneously, and we'll wait till we have good vasodilation, and then we'll begin our harvest. So roughly 10 to 15 minutes. That I'll frequently use for infiltration. I'll make a little small stab incision with an 11 blade, and then I have this infiltration cannula here, which you can see has multiple 1 millimeter holes on that, and this will actually, I'll do a lot of harvesting with this as well. This is going to start breaking up the plane, and then as you can see, I can inject a lot larger bolus of fluid. A little bit faster, kind of starts the dissection for you. Okay, make a little stab here. Awesome. Always using this hand, so I always know where my cannula is. Stay nice and safe. Again, avoiding this area where she had to harvest for her subclavian repair. You want to make sure that you're not too superficial. That's why you're always feeling it as well. And make sure that you're in a nice plane where you're subcutaneous, especially when you harvest. And now we'll wait 10 to 15 minutes, and we'll look and see how the color changes and everything starts to blanch. So let's finish prepping. Okay. So we waited about 17 minutes at this point. We're starting to get some blanching of the tissue here, which is exactly what you want to see, that vasoconstriction. So now we're going to start. So I'm going to go in the exact same ports that I use. I'm using the same harvesting cannula. This is, just one sec. This is just a little bit different than, you know, if you're just doing straight liposuction, because I like these cannulas. They're about 1 millimeter or so in diameter, so it's going to harvest the fat at about the size we already need. So again, I'm deep enough where I'm not pulling against the skin. I'm definitely in the fatty tissue at this point. And you can see that if you look at the syringe, we're harvesting some very, very nice yellow fat. So that's just one pass. We already got ourselves about 10. So even though I'm not harvesting for cosmetic purposes, it's still obviously important to make sure that we end up with a good contour at the harvest site. So we don't want to leave divots or dimples or anything like that. And for most people, there's going to be ample amount of fat. So what I usually do is I'll harvest from one side, and then I'll go back and harvest the same amount on the contralateral side. So that's about 20 on that side. So let's switch to the other side. So we'll put our cap on here, and we'll allow gravity to separate that. So as you can see, we're getting absolutely gorgeous fat here. We're maintaining a nice contour, very, very simple harvest. And it's nice because there's, like I said, there's not a ton of blood in this at all. That's going to separate out really, really well. So as you can see here, our fat's gravity separating. So we have our infernating, so that's red blood cells, tumescent anesthetic, beautiful fat, and then on the top you can see a thin layer of oil. So basically we're keeping everything in the middle. So what I'm going to do here first to start off is just I'm going to remove this infernating. Okay. Like I said, we have plenty of fat for her. Tap on that, please. So then now we're going to fill this up, and I'm going to centrifuge this. So because we have so much extra fat, I don't even care about that little bit. I'm just going to cast that over to the side because I'm not going to need it. So again, removing our infernating. Filling our fat. So again, here's our marked out area. You can see the area where we definitely need to fill right there in the middle. So I usually come at these from a couple different angles. I'll come at it probably from here, and probably from here. And why not just mark one there? But that way I'm going to be able to cross hatch and layer as I'm going in. And I'll give a little infraorbital block as well. You notice I didn't put any local anesthetic within the defect because I don't want to distort that tissue. So even after gravity separation, you can still see how much additional oils and infernating we got. So we'll continue to separate this out right now. So we're getting rid of the bad. Notice how I have the cap on still so the fat doesn't roll out. I'll take off the cap here. Turn off the infernating. So we harvested 80 cc's of lipoaspirate, including the fat and tumescent and oils, separated them twice, once and then centrifuged it a second time, and then now we have our purified fat here. So the next thing we need to do, get a cap on there, is we need to make sure that our fat is all uniform shape. So out of that 20, or out of that 80 that we harvested, we have 20 here. Plus, I know that I'm not going to need it, so I do have another 10 that we never even spun down. So I got about probably 45 or 25 cc's out of 80 harvesting. Huh? I'm going to start working it down. Now, I've already taken my PRP. So So like I said, I like to mix about 1 cc of PRP for every 9. So we have 20 in there, so I'm just going to put 2 in. So we'll start off with 1. And then I'll put in the other 2, or the other 1 of PRP. And then I'll get the rest of the fat. So I'll use a series of screens and filters here and just go back and forth until we have all this fat at the same time. Right now I'm using a 2.4, and I'll do this a number of times till everything is moving nice and smooth, mixing up the fat. And then we'll go to our next size. So we're now down to a 1.4. And that's moving really nice. Then we'll go down to a 1.2. I don't think we're going to need to go any smaller. There are some nano fat discussion that's also within this chapter. We're not going to do that today because I still want some nice bulk of some fat. And even though we mix PRP with it, we don't want to overdo the fat either. So this feels really, really nice. And I think we're ready to transfer into our 1 cc's. So I'll have you start doing this, and I'll meet you up top. Okay. So I'm going to use an 18 gauge needle. Let's give a bolus, please. I'm going to use an 18 gauge needle. You can use a no-core needle, which is nice because they don't actually have a lumen within them. We'll just use those 3, and let's start with our 1.2 cannula. So here, this is a little bit bigger, a little bit more of a bulk fill. So I usually start off by doing just a little bit of dissection just to make sure we have a nice smooth plane. And remember, we're going to try to layer this as much as possible. So I'm breaking up that little bit of scar. Fortunately, she doesn't have a ton. So like I was saying earlier, I like to come from multiple different angles. So I'm going to come from a little different angle here. At a little different depth. Doing about 1/10 per pass. And the important thing also is to make sure that you always know where the lumen is of your cannula in order to prevent overfilling toward your injection site. So already we're getting a really nice change. This doesn't feel bulky at all. It feels nice and smooth, which is exactly what we want. So that's 3, right? Mm-hmm. Come a little bit more superficial on this pass. Breaking up some of that additional scar that we feel in there. And just feathering it out.
don't want to have a line that goes from my injection point, so I'll just do a little squeeze, and I'll just squeeze out that little bit of extra fat because I don't need any contour here. I don't usually overfill because I just think that when you add platelet-rich plasma to it, I think it makes it nice. I think it increases the survivability rate quite a bit. So now I'll just come and look at it from some different angles, but I think we're looking pretty good. I said about 4, which we're right about 4 right now. Add just a little bit of contour down along the bottom part here. Feels nice and smooth. Right there was where her scar, there's a superficial scar here, so it's a little bit more challenging to bulk up.